Good morning, everyone, and welcome to day 2 of the 9th Medicine Annual Conference. Before we start the first track for today, I would just like to read out the housekeeping rules. For those of you who haven't registered, please register at the welcome desk located at the entrance to the hall. You will be handed over a conference kit upon registering. Please make sure to produce coupons at the food counters. Food counters have been provided in the conference kit. Please be on time for the sessions. Sessions will start and end as per the schedule provided. Keep mobile phones and electronic devices in silent mode during sessions. Please type your questions into the Google form attached to the QR code printed on the notebook. You can also engage with speakers in the Paul Brand Lounge during break times. The registration desk also has in-house books from various specialties kept for sale. Please have a look at them. Postgraduates who are interested in presenting cases during evening clinics report to the registration desk. Fill out the feedback form attached to the QR code printed on the notebook. There are separate toilets for men and women at the end of the corridor, and there are signs leading to them. Please contact the registration desk in case of medical emergency details regarding local cab services. For the speakers, we request you to kindly stick to time, and for the chairpersons, kindly limit the Q&A sessions to 15 minutes. Additional questions will be answered via email. We will now begin our first track for today, which is infectious diseases. I invite our chairpersons, Dr. Priscilla Rupali, who is currently Professor of Infectious Diseases at CMC Vellore, who is an accomplished researcher with multiple publications and expertise in HIV, a coordinator of International Short Course in Clinical Tropical Medicine, and also heads the Fellows in Transplant Infectious Diseases at the Henry Ford Hospital, Detroit, Michigan. Her areas of interest are education and training, HIV, travel and tropical medicine, and antimicrobial stewardship. We welcome you to chair today's session, ma'am. We would also like to invite Dr. Kurian Thomas, who is a senior consultant at Narubi Hospital. He was involved in developing India's integrated disease surveillance program as a World Bank consultant, shaping national health monitoring systems and creating surveillance and lab manuals. He's a national consultant and member of the Apex Committee for HIV/AIDS, design and evaluation of NAC3 and 4
good
programs.
evening, whatever time it is.
His areas of interest are disease surveillance and clinical epidemiology, ID and antimicrobial resistance. I would like to introduce our first speaker for the day, who's joining online, Dr. Kristin Nelson. She is an assistant professor in epidemiology at Emory University and holds a PhD in epidemiology from Emory with a background in biochemistry and molecular biology. She's published extensively on TB transmission, vaccines, and respiratory infections. Her notable work includes contributions to Lancet, Microbe, and the International Journal on Tuberculosis and Lung Disease. She is a recipient of the Charles C. Shepard Award, and her areas of interest are epidemiology of respiratory infections, particularly tuberculosis, with a focus on disease transmission, vaccine impact, and intervention strategies. Her topic for today are TB vaccines. Are we there yet?
Hi, everyone. Good morning, good afternoon, good evening, whatever time it is, where you are in the world. It is afternoon on Tuesday for me, and I'm so pleased to be here talking with you about a topic that is the focus of a lot of my research on tuberculosis epidemiology and specifically on tuberculosis vaccines. And I'm an infectious disease epidemiologist. I'm a assistant professor at Emory University in the Department of Epidemiology, and I'm really pleased to be here today talking with you about some of the advances in TB vaccines in the past few years, and what the implications of those advances are in fighting this disease going forward. TB is the leading infectious cause of death globally. It was briefly displaced by COVID-19 starting in 2020, but now in 2024 is again the leading infectious cause of death. India accounts for most of the TB cases, or rather the plurality of TB cases that are diagnosed every year. You can see here the countries that contribute most to the global TB burden. Most of those countries are in Southern Africa and in Asia. And what you can also see here is the trends of tuberculosis in India over the past 15 years. So the estimated TB incidence rate is around 300 per 100,000 population, and that has largely leveled off in the past several years. And you can also see trends in the estimated number of deaths caused by TB. So this rate has gone down in the last 15 years, but remains high, a little over 300,000 deaths annually from TB in India. Current tools that we have against TB, both to prevent and to cure TB, are effective. TB is a curable disease. There are drug regimens that are increasingly shorter and more effective for treating TB. And we have preventive interventions as well. Drug therapies that can prevent someone with TB infection from progressing to TB illness. But these tools, as you can see, as is shown in this plot, are not going to be enough to achieve the goals that the global community has set to end TB before 2030. So what you can see is that with current tools, this is the trajectory that we expect the TB epidemic to take in the pink line. With our current tools, we see the reductions in TB corresponding to the green line, but we really only see significant reductions in TB reaching those goals in the global plan to end TB when we utilize both current and new tools against TB. And one of these new tools are TB vaccines. And specifically here, we're talking about TB vaccines for adolescents and adults. So we know that vaccines are powerful public health tools. This is a schematic that shows the reduction in incidence of these different illnesses after the introduction of vaccines. And this is data particularly from the US, but it would tell a similar story if you were to show global data for the introduction of these various vaccines. What we know is that effective vaccines can have a dramatic impact on disease incidence when implemented widely in the context of vaccine programs. And so the title of this talk is New and Old Vaccines Against TB. And you might be thinking, as I'm talking about, new TB vaccines and new tools, that we already have a vaccine against TB. And that's true. The BCG vaccine is the most widely administered vaccine in the world. It's given neonatally in many countries around the world, including India. And this is an effective vaccine. It has over 80% efficacy at preventing disseminated TB in infants, and also has efficacy against pulmonary TB in infants. Curiously, this vaccine has very, very wide variation in its efficacy, depending on the setting. On the left is a plot from a systematic review that was done of BCG vaccine efficacy and studies that have reported on BCG vaccine efficacy over the course of about 30 years. And what you can see here is that these efficacy estimates range from below zero, so showing that actually the vaccine is not protective, it's harmful, to greater than 80%. And so these BCG vaccine efficacy depends greatly on where in the world it is used. There's a lot of hypotheses for this wide variation in efficacy estimates. BCG is not always the same strain, and so the differences in the vaccine strain can influence vaccine efficacy. There's also some hypotheses about human genetics and how ancestry influences its response to BCG, and also some hypotheses about exposure to environmental mycobacteria and the role that plays in TB immunology and protection against TB. But the overarching idea here is that there is a lot of variation in how well BCG vaccine works across settings. What we do know is that neonatal BCG vaccination does not prevent adult TB. And what's shown here is an analysis that was done showing that BCG vaccine protects young children from pulmonary TB, and that protection is about 40%. But protection wanes after about 10 years. So what we're seeing here is that as children get older, 5 to 9 years of age, 10 to 14 years of age, that protection from BCG wanes to nil. And this probably has, in part, something to do with the exposure and infection rates for TB in this key age group of kids and adolescents. So what you can see here is that TB vaccines, or TB incidence is high among very young children, declines, reaches the nadir around 10 or 11, and then starts to increase again in adolescence. And importantly, this increase also corresponds with the increasing prevalence of the type of TB that is easily transmitted, so pulmonary TB. Younger kids are more likely to have disseminated or meningeal TB, and older kids, adolescents, are more likely to have pulmonary TB, which is the kind that is transmitted from person to person. And so what this means is that a really important group for transmission of TB and high incidence of TB is adolescents and early adult and young adults. some background on tuberculosis transmission and the natural history of infection. So TB is transmitted when someone who has an active MTB infection coughs or otherwise expels the bacteria into the air, and someone else exhales or inhales that bacteria. We typically think of TB, the natural history of taking two paths. Either someone who inhales TB develops a latent TB infection with about a 5% lifetime risk of progression to active disease, or someone who inhales TB progresses to clinical TB more quickly. There are a few different methods by which airborne or transmission through the air is hypothesized to occur, and we think that TB is most likely transmitted via the aerosol route. So the reason that we're talking about adolescent and adult vaccines is 2 slides ago, I showed you that pulmonary TB increases in prevalence in adolescents and young adults. That's the type of TB that is transmissible from person to person. And so we know that most transmission of TB takes place in adolescents and young adults. However, our vaccine programs, BCG, is targeted towards infants, and BCG is very good at preventing infants against from severe TB. However, it's not a vaccine that really has much of a population impact beyond those that are vaccinated. So what you're seeing here is a modeling study that was done comparing vaccination of infants with vaccination of adolescents and adults. And so I won't go too much into the details here, but what you're seeing is the black line here on each of these plots is no vaccine, and the colored lines show different variations in a vaccine program. With the colors representing different efficacy of a vaccine, and the line types representing the duration of protection from a vaccine. And when you compare vaccinating infants with vaccinating adolescents and adults, you see that vaccinating adolescents and adults has a much larger impact on population TB incidence than vaccinating infants. And that's because vaccinating adolescents and adults it vaccinates and protects a population in which a lot of transmission occurs. And so when you protect that population, you not only prevent infection and disease, but you also prevent transmission in that group, which greatly reduces the community level TB incidence. There's been further work done on the investment case for TB vaccines. And what we know from that work is that if we were to have a 50% effective vaccine for adults and adolescents, a vaccine like that could cumulatively avert 37 to 76 million cases over from now to 2050, and from 5 to 9 million deaths from TB, and this is globally. A vaccine like this would be cost effective in nearly all high TB burden countries, and also considering that TB affects people in their prime of life, be a significant booster of economic growth globally. We're going to talk a little bit about the pipeline for adolescent and adult vaccines. I won't talk about each of these vaccines individually, but suffice it to say that there are a number of vaccines in the pipeline for to protect against TB. You'll notice that there's a number of different platforms represented here. So inactivated vaccines to live attenuated to mRNA vaccines, and those are shown by the different colors. And what you can also see is that there's a number of vaccines in phase 3. So vaccines that are at a late stage, which are, should these phase 3 trials be successful, could mean that we could have a TB vaccine for adolescents and adults in hand within the next 3 to 5 years. I want to say take a moment to talk about the so-called target use indications that are guiding the development of TB vaccines. And on the bottom here is shown the progression from MTB infection. So you can see the transmission represented here between 2 people. After someone develops a latent TB infection, they can progress to more severe clinical stages of TB. And these vaccines are being developed to sort of intervene at different stages throughout this process. There are some TB vaccines that are being tested to prevent initial TB infection, and there are some that are being tested to prevent, excuse me, to prevent TB disease. So being tested among people that are already infected with TB to prevent progression to disease. And there are also some being tested to prevent recurrence of TB among people who already have TB illness. And of course, what we actually are interested in preventing are the more severe forms of TB, so clinical TB. And so the most important thing that should be guiding the types of vaccines that we're most interested in, those are going to be vaccines that prevent the clinical manifestations of TB or active TB disease. I just want to talk briefly about two late-stage TB vaccine candidates. This is the first, M72-AS01E. This is a vaccine that's currently in phase 3 trials. It's being tested by Gates Medical Research Institute in the US and the Wellcome Institute in the UK. And this vaccine currently in phase 3 trials. Those phase 3 trials will expect to wrap up in 2028. And so that's the year in which we expect to have some data on whether or not this vaccine is in fact effective. The trial will run for 3 years and will ultimately tell us whether or not M72 is a vaccine that might be eligible for approval and licensure and ultimately use. The other sort of paradigm for thinking about adult and adolescent vaccination is BCG revaccination. So I just talked to you about M72, which is a novel vaccine product that was originally developed by GSK and is now being tested by some other organizations. But BCG revaccination is the idea that we would take BCG, which we already vaccinate, with which we already vaccinate infants, and revaccinate or boost protection in adolescents by administering BCG among adolescents and adults. And so this is an idea that has been tested in a few trials. Most recently, there was a trial a phase 2b trial that showed that BCG revaccination of adolescents was 45% effective against an endpoint of sustained MTB infection measured by QFT conversion or IgRA conversion. And this particular finding was in the context of a trial in which this wasn't the primary objective to evaluate the efficacy of BCG revaccination. And so a confirmatory trial, which will aim to more robustly test this result, will report out data a little bit later this year. And there are some other trials which are testing BCG revaccination in household contacts and pre-adolescents, which are currently underway. I want to take a quick moment here to recognize that there's been a lot of research on BCG in India over the years. So in the 1960s, there was a very large BCG vaccination trial in Tamil Nadu, looking at the impact of BCG vaccination in a community setting. And famously, that trial actually did not find that BCG vaccination was effective at preventing TB disease. as you'll remember from one of the first slides, there's been a wide range of efficacy estimates for BCG. In some settings, it's been found to be effective. In other settings, it has not. And there's been a lot of interest as more recent results, like the one I just showed you, have emerged about the efficacy of BCG revaccination of adolescents, to take a second look at this vaccine and to try to understand whether or not revaccination is a reasonable strategy. Unlike a novel vaccine product, we already have the BCG vaccine. It's already in use. It's being manufactured, and so BCG revaccination program is relatively more feasible at this moment than implementation of a new vaccine product. Some reanalysis of that trial that I just mentioned that showed little to no efficacy of BCG did show that when you restricted the study population to people that had received BCG vaccination at birth, so effectively, when the trial results were reanalyzed to focus on revaccination of adolescents, they did find an effect among adults of BCG revaccination on the order of about 80% protective efficacy, specifically in this group of 31 to 40-year-olds. And in fact, as a result of this reanalysis of the trial data, and again, some of the new data on BCG revaccination and its potential efficacy, that has prompted a programmatic study that is ongoing now in India, in over 500 districts, in which some districts are implementing BCG revaccination of adolescents and adults, and others are not. And there's a programmatic study ongoing to evaluate the efficacy of BCG revaccination. This, I believe, started in May 2024, and there's a source for this information, popular news source here, if you are interested to read a little bit more about that. So I mentioned two late-stage vaccine candidates, or rather one novel vaccine product and BCG revaccination. There are also a number of others. VPM1002 is a live recombinant vaccine, as well as GAM-TB-Vac and MIP. So there's other TB vaccines in the pipeline that potentially hold promise. And so these are in various stages of development, many in phase 2 and phase 2B, which will be producing results within the next few years about their efficacy, and could potentially be taken forward and approved and licensed should those trials produce favorable results. So I just want to say briefly, after reviewing some of the leading vaccine candidates, that a lot of the discussion and conversation now is about how we move from a successful vaccine candidate, or even once we have a vaccine that's approved, to a successful vaccine program. The WHO has recently put together a document called the Evidence Considerations for Vaccine Policy Development, focused on TB vaccines. And the goal of this is to try to understand the evidence needed for policy decisions for new TB vaccines, and ideally to minimize delays between licensure of the vaccines and formulation of vaccine policy. And so a lot of the upcoming challenges for TB vaccines are focused on their implementation. Paramount among those concerns is ensuring adequate access and equity and distribution of a new TB vaccine, in particular for populations that are at particular risk of TB infection and disease. Here, thinking about people living with HIV, as well as populations that tend to be excluded from vaccine trials, including pregnant and lactating women. So ensuring that a new vaccine can be available to these groups is incredibly important. Second, there's a lot of effort now to try to understand what effective vaccine delivery strategies might be, and in the context of limited supply, what priority groups for vaccination might look like in different settings. So this vaccine will be indicated in adolescent and adult population. That's particularly important when thinking about delivery strategies because there are not many vaccines that are given to adolescents and adults. Most of the vaccines are provided within the context of the EPI program for very young children. And so introducing a vaccine in this population will require some new strategies, including where that whether or not vaccination is venue-based. So for example, within schools or is integrated within routine healthcare system. And it's also important to think here about vaccine hesitancy. So the extent to which concerns about vaccine safety and efficacy might impact acceptance and uptake of TB vaccines. I think there's also interest in evaluating community impact. So what the potential community level effects of a vaccine might be. One of the the individual level effects of a vaccine are measured by how well it prevents infection and disease among people who are vaccinated. But some vaccines are actually quite effective also at preventing transmission. So understanding the extent of the overall impact that's due to some of these transmission reducing effects will be important in understanding overall vaccine impact. And finally, understanding how vaccines fit into existing TB programs is really important. We have a lot of interventions against TB, and so vaccines really need to, we need to understand how they are used in combination with other interventions against TB. For example, preventive treatment, which we know are effective and are already implemented in TB control programs globally. I just want to show some data specific to India here briefly. This was a recent modeling study that was interested in evaluating what the potential impact of a TB vaccine might be in India on TB incidence and TB mortality. So what you're seeing here is rates of TB incidence per 100,000 population. The blue line, which runs straight across the top, shows a baseline scenario where no new vaccine is implemented. The green line shows the impact that would be expected if a vaccine was implemented in the general population. And this is generally the population in which TB vaccines are expected to be rolled out is the general population of adolescents and adults. But one of the things I want to highlight here is what the impact would be if a vaccine were targeted towards so-called vulnerable groups. And so in India in particular, this study evaluated targeting of the vaccine towards people who are undernourished. That's a particularly important cause of TB in India and in many other countries. And so this study evaluated how effective it would be to people who are undernourished. And the benefit of a strategy like that is that you can see that it's not quite as effective as vaccinating the general population. But in the case where where vaccine may be in limited supply, especially early on in a vaccine program, this could actually provide significant impact, but at a far lower number of doses. And so understanding how TB vaccine programs for adolescents and adults might prioritize certain groups will also be important in planning for the rollout of these new vaccines. So I just want to finish by saying that, as I mentioned, a TB vaccine is not the only effective intervention that we have against TB. And so this has been likened to thinking about TB interventions as slices of Swiss cheese. Swiss cheese is a cheese that is notoriously has a lot of holes. And so the idea is that any one intervention is going to have holes or is going to have limitations, but that when you put many interventions together, you can achieve maximal impact, right? You can sort of make up for the the drawbacks of some interventions by the strengths of other interventions, and they can complement one another when implemented in parallel. And so I'd like to think about BCG vaccination and an adult and adolescent TB vaccine as one of many interventions that we have against TB, which include, early care seeking, screening for infection and disease, TB preventive therapy, and of course, effective diagnostics and treatments for TB. And so, we need to think about these potentially new vaccines as one tool in our toolbox in ending TB. So a quick summary, adolescent and adult TB vaccines offer great promise to reduce TB burden globally and in India. The pipeline for TB vaccines is diverse. There's a lot of different types of vaccine candidates represented, but there's a lot of pressure on the late stage candidates to perform well in ongoing and upcoming trials. So there's a lot of hopes riding on M72 and also some other vaccine candidates that are in phase 2B and phase 3 trials. And we expect the results of those trials to be available within the next few years. M72 is the leading novel vaccine product, but there's also renewed interest in BCG revaccination after some recent data has shown that it might be effective. And in fact, in India, this has led to a programmatic evaluation of BCG revaccination in a number of districts. The upcoming challenges for TB vaccines are related to implementation, understanding how these vaccines might be rolled out, and potential concerns around vaccine hesitancy. Trying to understand those in advance of vaccine introduction will be important to ultimately maximize the impact of new TB vaccines. And with that, I just want to say thank you for inviting me here today. I was delighted to give this talk and happy to take any questions. Thank you very much.
I have been a relative. Can you hear me?
Hello. Yes, I'm here. Can you hear me okay?
Yeah, essentially, I've been a little skeptical about the Stop TB program as such, because the level of the incidence of TB is not considerably changed over the last many decades. And in spite of having a very effective treatment program, the case finding and case holding has been a major problem. So however effective the TB treatment is, unless you have a very effective preventive strategy, which is cost effective, and vaccine would have been a good idea. But one of your slides just shows that it reduces from 200 per 100,000 to 150. That doesn't reach the target at all to make it a Stop TB program. So I think we really have to think about looking at it. Either we must have the method to actually, theoretically at least, to make the TB, eradicate TB, or then change the program. This cannot be both ways. This is like saying something with no hope of achieving it.
Yeah, I mean, I think it's a fair point that we have a lot of interventions against TB that we should see those being more effective than they are. And there's a lot of reasons why the interventions that we have, even though when implemented optimally, they are effective, why they don't translate to large reductions in TB incidence in places like in India, and also we find this in many other countries as well. So TPT, preventive treatment, is a good example where when implemented optimally, it is effective, but we just despite whatever policies and recommendations are put into place by WHO and by national TB programs, they just don't seem to move the needle as much as they should. And I think that's where operational research really comes in, to try to understand what are the factors that sort of influence the real life effectiveness of some of these interventions. And I think we'll have to do that as well for TB vaccines, because they're not immune to those challenges of needing to be practically effective in addition to being effective when they're tested in trials.
Thank you, Dr. Kristin. That was an amazing summary of the available vaccines and highlighting all the problems with TB elimination. We have one question from a person who's online. So the question is, BCG is a live vaccine, and we know that many of the Indians do have latent TBs. So will giving these vaccines result in its activation, and what are the chances they would cause disease itself?
Right. So BCG, it's true, is a live vaccine. And with live vaccines, there's always the concerns about safety, in particular in persons who are immunocompromised. And in India and in many other places, primary concern is people living with HIV. The BCG in general has shown to be safe in neonates, HIV infected and not, and so it's recommended regardless of HIV status in most places. That's a position that WHO has taken on it, and I think there are still questions about the both safety and effectiveness of BCG revaccination, especially in people who have either who are immunocompromised or who have had a recent TB infection. And so I think we're still accumulating evidence on BCG revaccination and the extent to which it is safe and effective across multiple population groups. Early signals suggest that it is both, but I think that that's one of the questions that we'll hope to answer with some of these programmatic research efforts and more formal research efforts in the context of trials. That particular concern also applies to other live vaccines that are in the pipeline, and so that's not specific to BCG. That's also a concern for some of the other vaccine candidates that are novel products.
So thank you, Dr. Kristin. That was amazing, and thank you for being available online to answer questions. It's a pleasure to have you talk to us. We'll go on with the next talk in the program, and that's updates in the management of TB, HIV, and AI, among everything, in infectious diseases. And I'll invite Dr. Kurian to introduce my colleague, Dr. Rajiv Karthik.
Did you see? No, Rajiv Karthik is the professor of infectious diseases in CMC Vellore. But he doesn't need an introduction to this crowd, but I invite him to speak on the topic.